we had on our pre-event slides as well. If you could rename your image in Zoom so we get the correct name and organisation, then we're able to put that on your attendance certificate. After the event, we'll be doing an evaluation survey, which will be emailed out. If you could please complete and submit that within 24 hours, that'd be great. Webinar recordings and presentation documents that will be available, the available ones will be emailed to you, and a statement of attendance will be sent out once we get your evaluation survey response in as well. Just highlighting some of the Gippsland Primary Health Network localised health pathways that touch on the subject we're going over tonight. So there's a list of those topics here. They're available via Gippsland PHN website. If you're having any trouble, if you're accessing those, just contact Gippsland PHN and we'll be able to help you there. Right, now we're getting right into it now. So tonight, the panel will be facilitated by Dr. Melanie Benson. Melanie's a palliative care physician with Peninsula Health and Gippsland Region Palliative Care Consortium. And our panel members, we've got John, we've got Laurie, Indra and Jenny. So welcome to our facilitator and our panel members. Again, we really appreciate your participation and assistance in this event tonight. Thank you. There'll be opportunities for questions throughout the presentation and Q&A discussion before we finish. So I'll stop my share now and we'll go over to Melanie.
I better unmute myself. Hello, everybody. Good evening. I'm sure I've either met some of you before or you've listened to me before, and certainly the same with John and Indra. Thank you for all of you who have come to our talks previously. And I see a few familiar names up there, so that's great. Look, this is a pretty different presentation from the ones that we've done already in the Time of Dying series. And a lot of it has stemmed from, well, the title has stemmed from, I confess that came from me, is around at the start of the pandemic, reflecting on a lot of the activities that were done in the aged care sector, but also anticipatory prescribing, advanced care planning, a lot of the flurry in the early stages of the first phase of COVID. If we stood back, we were really doing at a heightened pace what palliative care has been doing for years, if not decades, which is advocating for goal setting, identifying surrogate decision makers, identifying preferred place of care and death, ensuring medications are in place to allow that to happen, having difficult conversations in real time. And so COVID really just heightened that. And I think then when we went through the second wave, particularly those of us in Metro Melbourne, we saw how those things were even more heightened, but perhaps it revealed a lot more of the psychosocial distress that's out there around end-of-life care, but also a lot of professional stress around caring for people with either uncertain prognoses or even poor prognoses and imminently dying when one isn't used to managing that scenario. So that being said, this panel is really, we've got representative. Jenny's a nurse practitioner. For those who don't know the panel, Jenny's a nurse practitioner down in LRH and works predominantly in Warragul. Indra also works for LRH as a palliative care physician. He also works in Metro Melbourne. John is a clinical psychologist. Have I forgotten anyone? And myself, I'm a palliative care physician also, and I work on the peninsula and have worked in Gippsland for some time up until the pandemic. So this was a chance to talk about everybody's experience around death and dying, but particularly even in the COVID time. So we did open it up when you registered to have cases, but I thought perhaps we'd start with the participants. You can identify yourself in the chat or you can unmute yourself. But is there anybody who'd like to share a case that they perhaps want to share to start with, that the panel can discuss? Oh, Laurie. Yes, of course. Laurie is a VAD. Yeah, sorry. I knew I'd forget. I knew there was someone. And Laurie's the VAD navigator at Peter Mac, and has come down and talked to teams down in Gippsland, and has certainly had experience and has a case to discuss if we get to that, around the challenges of voluntary assisted dying, or perhaps the opportunities of voluntary assisted dying during the pandemic as well. Sorry, Laurie. Okay, so does anybody have a case that they would like to share? Nobody in the chat. Does anyone unmute themselves? No? All right. All right, perhaps we'll start with Jenny. Jenny has a case prepared that might spur us on. So Jen, can I hand over to you to perhaps present your case?
Thanks, Mel, and thanks for the opportunity to be part of the panel this evening. So as Mel said, I work with the consultancy service, so provide consultancy across the Gippsland region, and I've been doing some work particularly in aged care facilities. So I've chosen to share a case this evening of Jo, who's a lady in her 60s who has a diagnosis of a glioblastoma. She's experiencing a decline in her function and her cognition is fluctuating. And up until recently, she's been residing with her daughter and 3 young grandchildren, and her daughter has been providing her care. Unfortunately, with her increasing care needs, her daughter's unable to continue to juggle the care of 3 young children and her mum, and she is admitted to hospital. From that admission, she is then transferred to a residential aged care facility, into a transitional care program, and the discussions, I believe, that had occurred within the hospital was that there may be an improvement, which in some ways was problematic, in that the family's understanding was, and the expectation was, that she likely would improve. So whilst she's receiving slow stream rehab within an aged care facility, she continues to deteriorate, and then COVID hits. And suddenly there's a complete lockdown of the facility. A decision is made by Jo herself and her family that the best place for her to continue to receive care is within the facility. It's just not something that the family can provide. So the lockdown of the facility means the family can no longer visit. There's opportunity to have conversations via Zoom or such platforms. But with mum's fluctuating cognition, it really isn't an effective way for communication. So the family were relying on the regular phone updates by staff at the facility. So with no actual face-to-face interaction for many weeks. I think it was even longer, more like months. So of course they were extremely distressed as a family. They were left with constant questions of what's happening with mum. Is she okay? Is she getting the food and care she needs? Particularly with what we were seeing on television, on the news, the constant concerns around aged care, and when were they going to be able to see their mum next? The next time they were able to actually visit mum, she was now bedbound, mostly confused and agitated, and entering the terminal phase. So I received a referral at that time to provide assistance, particularly around managing her increased distress and agitation, but also providing support for this very complex, what had become a very complex psychosocial situation and significant distress amongst her family members. They were extremely upset at the deterioration and attributed blame to the staff. It became obvious throughout the conversation that there was a low level of health literacy, but also a lack of understanding about the expected deterioration with their mum's cancer. And I think healthcare professionals previously may well have attributed to that. Without regular interaction, the family did not witness her deterioration, which made what they were seeing even more difficult to comprehend. And the regular phone calls, although staff were updating on a regular basis. It's just not the same as seeing it for yourself. It doesn't seem real. Her son expressed, "They stopped us from seeing Mum. Next time we saw her, she no longer could walk. She can't understand what we're saying and she doesn't recognise us, and here she is dying." They'd promised their mum that they'd visit regularly, they'd be there for her, hold her hand, and this was all taken away from them. They were terribly distressed at the thought that their mum would have thought that they had dumped her and that she was not loved because they had promised her that they would turn up every day. They felt she was dying because of the rules and regulations that did not take their mum's needs into account, holding a belief that mum gave up wanting to live because of lack of family support and that their connection was disconnected. There was a significant amount of time spent listening to the family's narrative, which kept coming back to how a facility can stop a family who love their family member, stop them seeing her. All I could do was listen and recognise and respond to their distress and suffering and provide options for additional support. So clearly, unprecedented times that we're in, decisions were being made, I believe, based on risk aversion and maintaining safety. From the many families I supported during this time in the aged care setting, I feel there's a need also to consider maintaining quality of life. This is just as important for preparing and responding to outbreaks. Quality of life does not change in an emergency, although how this can be achieved does. I think when I look at some of the research over the previous months, there's been some research into lived experience of people living in residential aged care and what's been identified as a large increase in depression, anxiety, confusion in residents, increase in suicide, and a real sense of hopelessness, not knowing when this is going to end or see any improvement in their situation. And I think it's important that we recognise residential aged care as seen as places in which people live, and these are their homes. So this must be a reality, not just a description. I feel that the COVID restrictions will continue to have serious consequence, particularly to people's mental health, and have increased complex bereavement. So whilst we might succeed in keeping the virus out, we need to also take into account at what cost. So what's been highlighted for me throughout this pandemic, specifically related to aged care, is laying bare how we treat older people. I think there's been exposing intrinsic ageism, stereotypes and discrimination based on people's age. I think there's been a view to some degree that people who are aged are all the same. I think, which isn't surprising, that aged care is severely under-resourced and overworked. The importance of connection and the importance of recognising dying, because in my experience, if someone was identified as being in the terminal phase, it then allowed family members to come into the facility. So that was really important to be able to recognise that with the policies that were in place. And there was a real fear and trauma for staff, fear of bringing the virus into the facility and what that would mean. And one facility in particular, where there was an outbreak, there was a lot of judgment from community that was really difficult for them to manage and to work through. So my experience working across aged care during these times was an increase in distress of family, particularly increasing feeling of distrust of the facility and feeling helpless in supporting their family member. And I found it extremely challenging supporting family in these situations because of the policies and the restrictions that were in place. I could see that their connection and an increase in support networks was so important, but it was really restricted with what could be done as a health professional. And there's no simple answers to this very complex situation, but I hope this case study provides some food for thought, not only focusing on keeping the virus out, but focusing on what can be done to maintain a person's quality of life and support in a situation where family are restricted from being present. Thank you.
Thanks, Jenny. There's so much in there. We probably don't even need to do another case, but I wonder, does anybody have any questions they want to ask of Jenny about her case in particular, or any comments? Yes. So we've just been reminded, you can put something in the chat, or you can physically raise your hand, or you can raise your hand as well.
I suppose I have a comment to back Jenny up. I've emailed Melanie and I'll probably share in a minute, but I actually worked in an active COVID site, and the rapid deterioration in many residents, which was obviously different to Jenny's case, but that point of ageism, I don't know how many times we had to challenge paramedics that would not take our residents off site for appropriate terminal or palliative and terminal care, let alone the acute care that they needed. It was fascinating.
Does anyone else have? Thanks, Kirsten. And you do have a lot to share, so we may circle back to you. Does anyone else have any other comments to share? I might just reflect, and I wasn't going on. Laurie's got something to share. Yes.
I was just going to ask Jenny, when the family were allowed in, was that just as a result of COVID sort of restrictions easing, or was it that the staff went, oh, hang on, this lady's now really unwell and we need to kind of make an allowance?
So restrictions were easing at that stage, but it wasn't long after that this lady entered terminal phase. There was very strict criteria around prior to that when family could visit, and somebody needed to be on their end of life pathway.
Okay.
Melanie, I think, and Jenny, this is a very complex social and clinical phenomenon, I think, and even people in their later years, 70s, 80s and 90s, their most recent experience of something of this scale is probably, you know, the Second World War or something like that. But of course, that was somewhat distant. There's a couple of things that come to mind. One is that, and this might seem a rather provocative statement, but as a psychologist, there were two messages coming out of all of the stuff surrounding management of COVID and its impact. One is that we all needed to adopt obvious physical health practices like distancing and hand washing and so on and so forth. And the other was that it was very important to maintain one's mental health. And I think what Jenny's case sort of really poses for us is an incredibly complex dilemma. And that is that social distancing compromises mental health to some degree for most people. And so your example, Jenny, is a really acute kind of presentation, I guess, of that challenge, especially given that we know that social and emotional connectedness are probably the most standout predictors of mental and physical well-being. So at that sort of meta level, if you like, I think it forces us to confront things that we know, but perhaps have been brought into really sharp relief. I think the other thing is that physical health management historically trumps mental health management. And I don't think we can escape the truth of that. We haven't quite found a way to integrate and correlate and perhaps really deal with that complexity. But it seems to me, as in my area of work, that if it comes to the crunch, by definition, we'll always go for preserving physical life. But of course, mental health is a huge component of people's quality of life while they're living. And your case really highlights how difficult it is to get the message across, as does Kirsten's comment, that because people are in a particular stage of life, the validity of their needs is seemingly compromised for reasons that are difficult to really justify.
I think too, John, my experience within aged care across the region is it's very difficult to access mental health for people, that there is such a significant need, but to be able to actually find that help for them is extremely difficult. Sometimes it almost feels impossible.
And I think I agree. It's a coalescence of really vulnerable people. I mean, I think as you said, the phrase you're looking for, Jenny, is the fallacy of composition. So when groups are treated as a homogenous group and everybody's the same in a group, and it's the same for palliative care clients too. Outside aged care, everybody perceives outside palliative care that a palliative care client is an aged care person, and then becomes, so we can't get, and I speak from multiple sectors I've worked across, and certainly I see Mary nodding in the corner next to me, that in my experience in working in Gippsland, we had lots of trouble getting formal psychosocial supports for palliative care clients, regardless of their age. And I've had that experience in hospices in Melbourne, and it's an ongoing battle to get psychosocial existential supports for palliative patients. And I think residential aged care clients who are both aged care clients as well as palliative care clients have a double whammy, let alone if they've got a pre-existing history of mental health issues. So I can't, again, it's just ripped the Band-Aid off a huge issue there. So I think it's interesting, there's certainly the patients, but then I think, Jenny, you've touched a little bit on the grief of the family, both in the anticipatory phase, bearing witness, but also what's going to become complicated bereavement after the fact. Has anyone?
Absolutely. And I think every case I've been involved in over this COVID time, I would say is now complex.
And how is it dealt with? Yes, go, Mary, I can see.
Yeah, and it's just purely an observation during this whole period of COVID. We had a bit of a run on VAD patients, and I think we've had 4 or 5 patients go through with their VAD, and how I guess it was described as always beautiful and empowering. And I guess on the opposite side was these residential aged care facilities where the loss of empowerment of these individual residents and the loss of their autonomy. I mean, it goes back to a basic medical ethics of each and every one of us for that autonomy. And I think it really lay bare very evidently to us in this region, or certainly within our service, that the residents seem to be very disempowered, and yet some of our individuals who went through with the VAD, it was often described a beautiful death by their loved ones, and how they felt empowered, and they felt certainly in control. So that's just an observation, and yeah.
Thanks, Mary. Does anyone else have any comment on that?
I think you're tapping into the broader issue, Mary, that of the relationship between perceived control and well-being. And yeah, when people have a choice that they believe they can enact, it's a very different impact versus either not having a choice or having a choice but not being able to enact it. So I think that this is a really big issue for lots of psychosocial kind of challenges, and particularly around the issue of perceived control. And probably every day of the week I have a discussion with clients at some level, which is really an exploration of what they've got control in their life. And the truth is that people have a belief that they're in control of actually much more than they are. And these circumstances we're talking about have actually just exploded the contrast between what people hope might be their degree of autonomy, and in a crisis how that becomes incredibly limited. So, there's a kind of a cultural, social issue in general, psychological issue here, which has just been, I think, really affirmed in some quite stark and distressing ways. There's no question about that.
And I think I agree with you, John, and Mary as well. I think, and particularly, we must recognise that that's a very Western liberal recognition. And when we talk about the pillars of clinical ethics, we're talking very much, and there's 4 pillars, but in Western society, autonomy is number 1. And for clinicians and staff, that's where we get into, outside COVID times, that tension between autonomy and perceived control and self-determination versus beneficence and doing harm. I think what Jenny's touched on is the other pillar is justice and equity of access. So whereas Mary's talking about equity of access to VAD versus Jenny's lack of access to palliative care. And Laurie has a case in a minute where somebody who could access VAD throughout the whole process. So there's disparity in access there. When you flip it and you look at public health ethics, which is what was superimposed on our clinical scenario, it's not about autonomy. It's about a collective.
Societal.
And yeah, exactly, an entity, a collective entity. And autonomy doesn't have a place in that. And that's where the tension comes from, and that's where the distress came from, not only from the patients, but from the staff who were torn. The staff were torn, and it came to a lot of my nursing colleagues in a hospice setting who were like the staff, I'm sure, in aged care settings, who had to police the organisational and Department of Health rules, which had a public health mandate behind it. So the staff, I think, and I think, sorry, it's Kristen, probably has a comment on the impacts perhaps on staff. Do you have a comment on that, Kristen?
Certainly, like I said, I was in an outbreak site for 13 weeks and the impact to staff was extraordinary. Not only are they dealing with volumes of PPE, they have no idea how to, manage on a daily basis, but people that they've cared for many, many years in some circumstances, suddenly deteriorating in front of them. And when we've looked at our mortality we had very few deaths in the site I was in, but the few that we had deteriorated so quickly in front of us that we couldn't pick it. There was, they just desatted in front of us and they were terminally unwell in an hour. That was a challenge. And obviously impacted greatly on the staff. If I can just pick up one point, Melanie, that you made around the impact to staff and I suppose access to services. There were so many, in aged care, we are so frightened of the punitive impact of non-compliance that we held a fairly firm line that people couldn't visit. So to Jenny's point, I'm sure the site was torn about what they should or shouldn't be doing in allowing people to visit, but so frightened that the commission would learn of a visit of a family, maybe in a scenario that they shouldn't have, and what that might mean for them in terms of compliance against the standards and then the impact of funding and so on. So it becomes this cyclical monster, and certainly did for us.
I know for myself, I found myself feeling extremely torn and guilty to some degree that I was able to go in and provide a consult, and yet the family members could not. I was extremely torn by that.
Yeah, I had the same experience, Jenny, to the point that one time when I was allowed in to see a patient, I FaceTimed this patient's son. So I was like I was going in there to be that connection because I was allowed in, but he wasn't. And it was pretty horrible because he'd only seen his mum a week earlier and she'd become jaundiced in the time that he saw her. He's like, oh, she's yellow. And so that was, like those things were happening that they weren't aware of. And it was only that I was like the go-to that was allowed in. So, yeah.
I found myself the same, facilitating conversations, having, the resident family member and having, a round table conversation. Not ideal though. But
yeah, not ideal at all. And yeah, especially when you're in full PPE, it's pretty difficult to have, really good conversations, especially with the elderly.
Thank you. Laurie, whilst you've got have a sip of water, whilst you've got the microphone, before maybe I'm putting tags out there in my brain for a minute, but Laurie, do you want to talk about your case, your experience with voluntary assisted dying and the navigation thereof through the pandemic, and what that's sort of, how you can reflect on some of the challenges we've just talked on, but how it sort of, again, has crystallised what's been happening in the VAD end of life space the last 18 months or so?
Sure. So it was interesting when Mary said that, you felt that during COVID there had been more probably more people accessing VAD, and we got asked that a lot at the statewide service, have more people been asking? And it was really tricky because VAD's only been around we only had our first anniversary in June, and so we've never done a winter before or a year, and then of course 2020 is COVID, so it's very difficult to know if the numbers were more or less than they would have been. Having said that, our monthly numbers of inquiries in July and August were pretty low, and then September we had a 75% increase in inquiries to our service. So that's not necessarily people who have gone through with it, but people who were inquiring. And we sort of put that down to, we were coming out of restrictions and perhaps patients were starting to have some more face-to-face conversations with their doctors and the nurses and the people that they were comfortable with. And perhaps that was where it was coming from. But we've had a few challenges, obviously, with access to aged care facilities during the pandemic. But I have a case that actually, when we first got the call, I went, oh, I'm not sure how we're going to manage this. But in fact, it ended up being, I guess, a positive story, especially for that aged care facility, that at a time where pretty much any press that had aged care in it was all very negative. So we got a phone call from a GP of a lady who I'll call Mrs. E, who was a lady in her 80s, was a resident in an aged care facility in Melbourne, had been there for about 3 years, and had originally lived there with her husband, who she had watched pass away. They had a shared room, and she'd seen him die about 12 months earlier, and found that very traumatic, and had been very clear that if she ever became unwell again, she'd had a past history of bowel cancer previously, but that if she ever became unwell again, she wasn't hanging around like her husband did. And so she had some episodes of abdo pain and PR bleeding, and was sent for a CT scan of her abdomen. She was quite independent lady, and otherwise up until that point pretty well. Because she left the facility for a scan, she was then placed in 14 days of isolation as soon as she got back, so she wasn't to leave her room. And so she got the news from her GP that she actually had a massive tumour on her pancreatic head from that scan, by herself, because she had no visitors. And she just said to the GP straight out, well, thanks very much, I would like to access voluntary assisted dying. And to her GP's credit, she hadn't done the training, didn't know much about it, but gave us a call straight away and said, I've got this lady, and can you help her out? So we spoke with her son with her consent, and he was very supportive. But he worked in an aged care facility separate to his mum's, and so he was not allowed to attend her aged care facility because he wouldn't be allowed back to work. And they were in lockdown also, and she was in her isolation. So it was kind of, even if I had been able to work around that, his work wouldn't have allowed him back in. So we needed to find doctors who could come to the facility, or who would be happy to come to the facility to do her assessments, because we weren't allowed to, she wasn't allowed to leave. So I went to visit her myself first, and the facility were actually very, very accommodating. They were happy for any healthcare professionals to attend as long as we wore full PPE, which obviously was fine. I was a bit nervous, to be honest, as someone who's hasn't really been a clinical nurse for a bit, and living in Melbourne and taking myself off to a nursing home. I timed my visit where I knew I wouldn't be seeing any patients for the rest of the day, and I could come straight back and have a shower. But I went and saw her and provided her with all of the information, FaceTimed her son so he could see her, took photos of the flowers that her daughter had delivered so that we could text them to her. And she was very clear and definitely had capacity about what she was asking for. And we were able to get to a GP and an oncologist to go into the facility to do her assessments. And by the time we had started, she was, probably by the time I got there, I think we were on like day 7 of her isolation. So as we were reaching the day 14, the facility had some facility-wide COVID tests that they kept coming back negative because they'd previously had an outbreak. So at this sort of near the end of her 14 days, they were starting to relax a little bit with restrictions, and they allowed her son to come in for her final request, and they allowed witnesses in as well, which was really great. We have had cases where witnesses have stood on the other side of the window with the window open because the aged care facility wouldn't let them in to witness the document signing. So we were very lucky that right the way through this aged care facility were very supportive. It was their first experience of a resident going through the VAD assessments. And so they were pretty nervous, but very keen to be able to support their resident. She'd lived there, as I said, for a long time, and she was much loved by the staff. So we provided them with education on the process and what would happen during the pharmacy visit and what would happen on the day. And so we provided all of that via Zoom. And there was a particular care coordinator who sort of took it on board that was going to, she was going to be the one on the day to really manage this lady. Her family were very supportive. However, they felt very strongly that they just couldn't watch her take the drink. They said, I'll be there, I'll hold her hand, I will step out of the room when she drinks it, and as soon as she's drank it, can you get me back in and I'll sit with her. So it was really important that we educated the nursing staff on what might happen, and making sure that they were comfortable and had the opportunity that if they weren't comfortable being involved, that they felt supported to tell their manager that, to say, I don't want to work that day, or can you put me down in a different wing, because the family really needed that support. And we weren't sure. I kept saying to the son, if she decides on the day, because she kept saying, well, as soon as pharmacy deliver it, I'm taking it. And I said, okay, well, we can prepare for that, but she might decide not to when the time comes. But true to her word, she got up that day, and then the staff at the aged care facility took such pride in, they got there early that day. They had more staff on than they usually would. They got her up for a shower. They said how they did her hair, they put some lippy on, and they just said they wanted to give her the best day. And it was just, I did a debrief with them the day after, and they were so proud of what they managed to pull off, really, that against all the things that were going on during COVID, that probably that first phone call that I made to the aged care facility, they could have actually just said, no, you can't come in, or no, your doctors can't come in because they work at other places. And they were happy to accommodate within that we mitigated risk with PPE and how we went about it. And her GP, who hadn't done the training, was there on the day and really supported her family and her. And it was just a really nice, it was a really nice reminder that everyone's participation in VAD, you don't have to be, you don't have to have done the training or be, a VAD doctor, but there's different levels of participation. And for her GP, she just really wanted to be able to support her. And she was obviously very interested and invested in her. And so she was there with her on the day. And that's probably all I've got. And I wanted to share it because at the time, that the nursing staff in that aged care home were so, like, they were so proud of themselves that they were almost crying, or some of them were. And I thought, imagine working in aged care in 2020, everything's doom and gloom, everything's the worst case. And they were just so proud that they were able to, you know, to give their resident the send-off that she had wanted, and her family were very grateful. So it wasn't all bad.
Thanks, Laurie. Does anybody, first for the panel, does anyone have a comment or question of Laurie about the case before I widen it out?
Laurie, I guess I'm curious as to whether, or is there an opportunity for the aged care facility itself to sort of disseminate that experience? Because clearly this is a facility example of kind of patient-centered care, you know, par excellence. Really, they went the full distance in terms of trying to create that outcome. So, because one of the issues here, I guess, is that it's, you know, in terms of trying to change attitudes and beliefs and so on, it's much more likely you'll get attitude change when it comes from a like source rather than an unlike source. So, is there any talk about how that as an experience might be educative for other facilities?
Yeah, so we ran a webinar that was aimed at aged care facilities in October, and we had 160 attend from aged care facilities around the state, and we asked one of the clinical care coordinator to be a panel member on that and to share her experience. And I'm just trying to think. I think we were allowed to say the facility that she was from. I think we did. But yeah, so she definitely shared her experience. We had 2 panel members from different aged care facilities that had been through a VAD death. The other one was a little bit different to where she didn't want anyone to know, including, you know, so all the other residents of the nursing home went, oh, well, she was here for breakfast yesterday and now she's not. And so the difference is in how the staff managed that. But we definitely wanted to get the nursing staff member from this particular facility to share their experience and how they supported their staff through it, and how they just really felt as though that was their task to you know, to support their resident in her wishes.
And do you have a sense of what the impact was on the audience by their comments or their questions? Or
yeah, look, they were very engaged. There was lots of questions. There was lots of questions, and I can see one in the chat about the other lady who didn't want anyone to have known that she used bad. And so the way they got around that one was that they said she died in her sleep.
It's poignant for me as a palliative care physician, and I wonder what you think, Indra, and I'm sure there's a couple of other palliative care clinicians that find it really poignant that all those stops were pulled out for a VAD death, whereas we would want that, all that attention and all that care to be given, and then preparation and consideration of family members for every death, regardless of whether you choose it. I mean, I think COVID has made it clear that the one thing, you know, in crystallising end-of-life care is that the deaths from COVID, as Kirsten has mentioned, happened very quickly. And I was, I can't think of the word now, cyber support is what I was going to say. We had a COVID ward where we had a lot of the patients that came from residential aged care facilities to our hospital for care during that time because their residential aged care facilities couldn't cope. And then of a cohort of all those COVID positive patients, they died, and they often died very quickly. And so it was really important. That was part of and this is a model of care that has been quite successful if it happened again, is that, you know, I was in the background prompting everybody to have EMOs, whether they were used or not, prompting them to have conversations with family and perhaps have what I call discretionary visits. So they didn't have to wait for the terminal phase, but perhaps if they were even in the deteriorating phase, that they could come in and spend time with their family, because again, they've got that choice of being with them when they're coherent, or a lot of these patients have dementia, so at least could recognise them rather than the terminal phase where they're unconscious. So I think that would be an important thing down the track. But I think that's what I find very poignant about your story, Laurie, is that one would hope that we could get to a point on both tracks that we could do that for everybody, regardless of the way they determined how they wanted to die. We could do that for everybody. Indra, do you have any other comments on that or
Yeah,
experience?
I was thinking the same thing about how much effort he put into that day. If we have that sort of care in the other patients, because this becomes only for a one day, but what about the other patients who go through this for a long time and they don't get that care? I think that reflects like what our focus and how we could improve things for the other patients and what that means to the patients who are going through things, and how we could support them and make them make those decisions even if they want to live, how we could support and be the best care, support the best care and provide best palliative care. Yeah, it's unfortunate because I have been working in a lot of COVID patients in the nursing homes and seeing physically and remotely as well. And what I found was the staffing having the difficulty with the communication with PPEs and things. I was just wondering how, Laurie, that conversation about VAD went with full PPE, how much it would have been difficult. Like even having normal palliative care and end of life care discussion was very challenging in that situation, even being physically there, but with a full PPE, and especially the elderly population who is in the nursing home, they have the difficulty even in a normal time to have the communication with hearing impairment or sometimes the language barriers as well. How did you go with that, with especially having that very
yeah, it was definitely difficult because the mask and the face shield and then the gown you're wearing makes noise with every little move, and so I found myself pretty much yelling almost to make sure that that she could understand. I had something else that just popped into my head and I've lost it. It was difficult. It wasn't, and it feels really impersonal as well. Like I think John, I think it was when we had when we did a bit of a test call before, and John said one patient that he's seen in his practice showed up with a long fringe, a mask to hear, and all he saw was her eyes. And it's really difficult to make connections with people when you're having really massive conversations when they can't see my face. I wander in just dressed like everyone else, and I'm here to talk to you about how you're going, how you might like to die. It just makes it's very impersonal. So regardless of the fact that they can hardly hear you and they can't really use visual cues, it doesn't seem like that. It doesn't seem like the ideal way or the nicest way to be delivering that sort of information.
I think it's interesting you're making, it was still as difficult as it was, Laurie, and you were dealing with a patient who had actually made up their mind by the sound of it. She was quite clear and she'd actually formulated a decision, based on other experiences and so on. So, to that extent, it sounds like if it was ever going to be an easier conversation, it was more likely to be with the person who was that clear about and that determined about their decision. So, in lesser clear situations, I just can't imagine how complicated and how difficult that would be.
Yeah, and I guess it wasn't difficult in the sense that I was delivering her perhaps bad news. It's just more I want to be really clear that people understand what the information is that I'm giving. And I did have another gentleman who was in an aged care facility as well, and he was really deaf. He just kept talking over me and his oxygen concentrator was making that much noise. And I thought, I don't know, like I didn't get the sense that we were really communicating very well at all. And yes, I guess, yeah, there's all of those added challenges with the PPE and at the moment. So
Thanks, guys. Does anyone have a comment before we maybe pivot on to something else? I wonder whether, just checking the chat. I wonder if we could talk a little bit more about, and maybe John, you'd be helpful with this, but anybody, on how to help these patients who have borne witness going forward. Have you had any experience? Because again, those of us who are in general practice or in residential aged care facilities or in palliative care doing bereavement, how to hold that space where people have been so disempowered through necessity in their grieving down the track, and that includes staff as well.
Look, I think I've had a couple of clients who've had Zoom funerals. And so from that perspective, people have given feedback on both of these are people whose parents are in the UK. And so I guess that's a sort of a biased sample in the sense that these are people who already have a degree of separation from their parents physically, and probably at some level are already aware that they could get the phone call in the middle of the night at any time. So that's been that kind of experience. I guess it's interesting, and I kind of harking back to what Jenny was referring to before, and I was looking at some research before tonight, and at least one article that looked at 1,600 bereaved adults. Basically the conclusion was that the grief severity was no different during the pandemic compared to before. However, experiencing a recent loss during the pandemic elicited more severe grief reactions than before the pandemic, suggesting that dealing with the loss may be more difficult, and therefore there's other issues. I mean, I think it's so complicated because grief is a social ritual for many people. Funerals are part of that, etc., etc. And I mean, I guess technically we probably haven't got any people who would fulfil the formal criteria for persistent complex grief disorder because 12 months hasn't elapsed yet. So that's the sort of technical issue. I don't think I've really got a meaningful comment to make, except that it comes back, I think, to issues, and you nailed it before, really talking about autonomy linked to expectations about how things should be, and how, in a sense, poorly prepared we are in a very affluent Western democracy to deal with things that we didn't expect or we just don't want to have to face up to. So there's a whole philosophical, existential kind of backdrop to this that is very, very relevant, I think, particularly to issues pertaining to anticipatory discussions and the skill of clinicians to read things and perhaps even initiate discussions, as well as obviously being able to react to things in the moment if things change very quickly, as they have obviously for a lot of patients. So I'm not sure. I haven't seen the direct experience yet with people coming to me and saying my problem is COVID-related complex grief. Maybe it's because I'm working where I do, and our actual exposure has been quite minimal, thankfully, in terms of numbers. But I think we've got a lot. There's a lot to come out yet. I'm sure of it.
Yeah, and I don't disagree. What I think, I wonder would be helpful for anybody on the panel or beyond to, and sorry if you can hear the printer, someone in my family's decided now's a good time to do some printing, is talking about how we hold that existential anxiety, and this is something that we all do a lot, of how we do that in times of uncertainty. So how do we, perceive control that anxiety that arises when our perceived control is not what it is. So we all went through that existential anxiety when we went through COVID, because we realised how much of things we couldn't control ourselves, whether it be the liberty of being able to walk around without PPE on, whether it was when we could see that we should be having discretionary visits and advocating for our patients to say, you know, going head to head with our organisational manager saying now's time for this person to have a visit, even though they don't meet that. But then how do you talk to patients who are dying, who are fighting every step of the way for control when they clearly don't have any control? What are some strategies that are have been really helpful for people in that sort of setting? I'll come back to you, John, because I'm sure you've got plenty. Maybe you, Jenny, have you got anything to offer in those sort of situations that you've worked with clients to offer?
I think in my experience, just listening to people, often they come up with solutions themselves as they talk through their experiences, and perhaps have had situations in their life where there's been, you know, a lack of control, and they've been able to draw on their own experiences. I don't really have anything else to offer. I'm sorry, Mel. I'm not. Yeah.
Indra, do you have any experiences to assist?
I mean, sometimes in a way this has impacted everyone in the society, so it becomes a bit more generalized rather than personal, so that they can relate to, because they can relate to the other people who are impacted as well. It becomes a bit more normalizing. So in a way, saying that this is not like initially like their personal loss of control. It's more like as a society, in the area we lost the control as a population, so that becomes more normalizing for them and to relate to others. And as Jenny mentioned, sometimes they have their own thoughts of how to deal with it and come up with when you listen to them. But it's identifying, sometimes being creative, and especially the technology is the other thing which can help in this situation, because people start to use more and more because they found that at least that's the way to connect with others.
I think, Mel, too, for me personally, it made me even more aware of that uncertainty that our patients feel, because I was feeling that uncertainty myself, and how disabling that can be.
Yeah. How about you, John, with working with clients who are faced with, you know, exactly what we've just talked about, that scenario? What are some strategies you work with your patients or clients to deal with the day-to-day?
Well, I think it's really difficult to package it up. But the one issue I think is, and it seems really obvious, we probably all do this to some extent straight off the bat, but working from the point of view that whatever it is that the client's struggling with is really significant for them, and at the very first validating that, and creating, at least as far as possible, a trust relationship which allows difficult conversations to be considered, let alone engaged in. If I could just sort of divert for a moment. I had a 73-year-old woman come in today for the first time, who I spoke to on the phone about a month ago, and her presenting specific problem is an enduring fear of the dark that she's had since she can remember. And she thinks it's a very silly problem, because why would you be scared of the dark, you know, when you're 73 years old? And of course, the next question is, why has she come to see me now? Well, the reason she's come to see me now is because her life partner has had a couple of medical crises, And she's now starting to anticipate how is she ever going to live by herself in the house and manage being there at night. You know, I think in some ways she was expecting me to almost join her in her perception that this was a rather odd behaviour for a 73-year-old person to have a difficulty with. But actually, you know, she's got a whole lot of other predisposing characteristics. You know, highly anxious parents, and strong history of depression in the family, and exposure to some vicarious, if not direct, trauma as a child, blah, 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 blah. So I think validating and trying to get a sense of what the person's story is for what it is. You know, we talk about non-judgmental stuff, but I think trying to, or having an attitude which says, in order for me to be able to work with this person, the first thing we've got to be able to do is establish trust so that these conversations can be had, that I'm as a clinician robust enough to have them, that I don't necessarily have the answers, but I've got 2 ears and 1 mouth, which means listening is twice as important as talking. As far as possible, trying to find out what's firstly important to them. I think the other question that's quite challenging but also really necessary is getting to a point where it's possible to have a discussion around what's realistic. I'm not sure I'm going to be able to cure this woman of her nyctophobia, but and I said that to her today, but I'm pretty confident we can do some things that will make a difference to 73 years of suffering, hopefully. So they're the sort of general attitudinal things I guess I come to the consultation process with. But I think one of the more challenging issues in this particular context is how do we go from that initial kind of trust building to how do we have the conversation about what's likely, you know, what are we looking at, and what's their understanding about that, what have they thought of themselves, picking up Jenny's point, you know, and that takes a bit of time. It doesn't take a lot of time, I think, if you're courageous, and the patient is too, and you can foster that in them. But you know, those conversations can be had, I think, with the vast majority of people, given, of course, that many people's experience of the health system is that they rarely get listened to. So I think if you can, I mean, that's a provocation to put it that way, but you know, when they have a genuine experience of being listened to and validated, my experience is that patients really notice that.
Yeah.
I agree, John. It's about listening to understand rather than what I often see as people listening to respond. I find that really powerful.
And I think, you know, somebody said to me a number of years ago that patients don't expect us to be perfect, but they do expect us rightly to be honest, because we've got control over whether we're honest. So I think, you know, there's somewhat attitudinal things, and then hopefully learning some skills that will actually allow you to communicate that.
So I think that's really helpful in individualizing it. So again, as you say, Jenny, individualizing it and individualizing people's different experiences, John, but also their coping mechanisms, and really getting to what's going to make a difference for them in a short period of time. We're not going to fix all of their problems. We just need to make life as manageable as possible for them now, whilst normalising, Indra, that it's an experience for all of us. And I think now, if none of us have learnt from COVID, that experience that our patients have gone through, that sheer terror of uncertainty, I think we've really missed an opportunity. And I think just before I move on to Annie, who's got a comment to say as well, is that my experience has been very much the same, that if you give people that opportunity of connection, it's really precious, and it doesn't take a lot of time. It just takes an investment of time and listening, active listening. And I often flip it as a practical technique of saying, look, we don't know what timeframes you've got. We don't know what's going to happen, but let's play with the worst case scenario. What if you are going to die tomorrow? What do you need to do? What's really important? Again, it's about getting to what's the nut nuts and bolts of the. If it was only a week, what would you really want to get done? If it's only a month, really to get them to think about, you know, acknowledging perhaps they still have hopes for chemo, radiotherapy, but let's just play with what's really frightening you. Not play is not the right word, but, you know, let's just think about what's really frightening with you and let's just confront it. But again, you have to individualize it to a patient. But that is a one way of holding that space and holding time, because we don't know what's going to happen with time. So chunking times into smaller, discrete, and then I'm sure, John, if you had an hour and a half, 15 hours to talk about anxiety and how to bring everything to a moment, there is always control within one moment. So all of those sorts of things. You're on mute, John.
Oh,
If I could simplify it as a bit of a take-home idea for all the people participating and maybe the panel to consider. Generally speaking, grief, anger, depression live in the past. Anxiety is the only emotion that lives in the future. And, you know, the kind of irony being that when people are actually in the present and having a discussion about what's going on right now, often there's very little distress, but it's hard to get people's heads around that. I just think one of the things that, and I hope I'm not jumping in on Annie's parade here, but there was an article that some of us were able to have a look at before tonight that was sent through by one of the participants. And I just want to make, I just want to quote two parts of that, because I think in essence, this really encapsulates the fact that there's always something we can do, even if other things haven't happened. And this article is talking about the issue of how still the stats for advanced care planning are disappointing. And the quote is, rather than emphasising the need to make treatment decisions in advance, quote, the real decision is how do we help families, and I'd include patients in that, make better decisions at the point when important decisions need to be made. Talking about likely prognoses and alternatives is hard work, but these skills can be taught. So I think even if the ideal sort of advanced care kind of stuff hasn't happened, and even if it has, of course, because of the unpredictability of people's lives, we've still got to be able to have these other discussions when things change. And it's not an if, you know, it's not one thing or the other. It's actually a combination of all of that stuff. But I think one of the major issues is clinicians having the skills and then developing the confidence, because that's the order: skills first, confidence second, not the other way around.
That's great. Thanks. Okay, Annie.
Oh no, that was fine, John. You did rain on my parade. No, not really. I just wanted to talk a little bit about a comment about uncertainty, which is a little bit of a flip to what we've been talking about. In the oncology unit, I asked a few of the patients at the start of COVID, when there was a lot of uncertainty about everything, you know, how they were feeling, and many of them kind of said to me in a way, not so many words, but that they're so used to dealing with uncertainty when they had a life-limiting illness that it was something that they'd actually developed some strategies to deal with as well. So I thought that was kind of really interesting. So you have people saying, well, I'm used to not knowing or being anxious about what might be coming up with my scan or my consultation or the future. So, yeah, you know, I just have to kind of go with this. I've learned to kind of calm myself down. So when you're just talking about strategies to deal with it, I thought that was, you know, a good one that came from the patients.
I think what you're revealing, Annie, is that humans get good at what they practice, you know, and some people haven't had very much practice at dealing with uncertainty. You know, in many ways, we'd say that's a desirable thing, but clearly there is, you know, the old saying, there's no resilience without challenge. Some people have had so many challenges, they adopt a philosophy or an existential perspective, which says, well, you know, for the moment I'm here, I'll give it the best shot I've got. And so there's an expectation component of that, which is sometimes difficult to nail down, but it's very clear when you see it. Yeah.
That's it.
Thanks, Annie. Does anyone else have any comments from the floor? We're not a scary bunch. So I'm scanning, looking for hands. No hands. We've talked a lot. Oh, go for it, Mary. Go for it. I can see your physical hand. Turn your mic on.
Sorry, I'm a bit compromised here. I guess with all of the COVID and certainly, you know, having to have those difficult conversations, you know, generalists. So, you know, I think around the world, the palliative care sector came to the fore and taught our colleagues and were there, you know, advising them, facilitating, helping them, mentoring them, I guess, in having these difficult conversations. Do you think there'll be, and I guess this is open to the panel, but I guess is the hope there that there'll be more funding put at, you know, we have to, it's mandated to do our basic life support. And I mean, this comes back, this question was asked at a conference I attended, I think in 2009. And, you know, but yet it's not mandated to have these really good therapeutic communication skills that I think everybody in healthcare should have. And maybe, you know, I was hopeful in one way that maybe COVID it elevated this and showed that. And so maybe there'll be a little bit more funding. What do some of the panel members think about that?
I think there's no question about the need, Mary, and I think one of the I have a connection to the program at Deakin, and you know, there's been a lot of work put into maintaining the program through Zoom, particularly for the students. I think one of the real challenges is how do we, you know, can we teach these skills remotely? I'm sure we can up to a certain point. In my own area, my colleagues and I decided not to go to Zoom for our own training program, and I feel pretty comfortable about that now. Unfortunately, there's been a loss of momentum, of course, but look, I think there's absolutely no doubt about this. The demonstration of the need for genuine compassion and empathy, and all the discussion we've had around the elite status of the VAD patient compared to the other non-VAD person, how that gets treated shows us what the potential is when people pay attention and take patients' needs seriously. And in one sense, we've got no excuse for doing this better.
Indra, you look like you had something to say.
Yeah, I wish that this would happen very soon, but I'm not sure how it will, but it should be something for everyone. And any time in their career, they should have that formal, because people take it as a thing that naturally comes, but it should be a skill that should be learned, and it should be done in a way that standardized for everyone and across the field. And it would reduce some of the anxieties, not only for the patients and families, but for the healthcare workers itself, and them to be more confident.
Jenny, did you have a comment? Turn your mic on. Are you on? Turn your mic on, Jenny.
Sorry, something went wrong with my screen. No, I absolutely agree with Indra. It's such an important area. And I was at a facility the other day and we were talking exactly about this topic, about, you know, how this can be learned. And the staff were really struggling with difficult conversations. And it would be wonderful if, you know, it was an expectation that people had to do a yearly communication training day. In my experience with actors, has been a wonderful opportunity for learning and reflection and support from other colleagues, and seeing how others, you know, are able to communicate in those difficult times. I don't know that there will be funding for such a thing, but I think it should be really supported within organisations to support staff, because it makes such a difference to the distress of patients and families that we're dealing with every day.
Melanie, if I could just throw something else. Indra made, I think, a very useful, really important comment, because he used the word everyone, and these skills aren't actually specific to healthcare. Another of my clients came in today, and she's got a 4-year-old daughter, and mum's been struggling a bit with work and COVID and homeschooling and all that sort of stuff. And she said to me, we've spent a lot of time with our kids teaching them, you know, showing them emotion books and talking about emotion language and talking about how they feel. And she said to me that my daughter said to me the other day when I was rushing around trying to get her into the car to go to kindergarten, Mum, you look like you're really nervous. And I'm thinking, this is what's possible at 4 years of age. Boy, there's a lot of potential for us to do a lot better than we have. So it's trying to, I think, package this into, you know, a career or a postgraduate or something like that. Ideally, of course, we'd be starting, you know, with for the same reason we teach kids spelling. But that's probably a bit hopeful.
Yeah, but I think it really comes to prioritising and capacity building, as you say, from a society into the healthcare professions. And I think it's not just learning it once, it's a commitment to that skill set more than anything else. I mean, I think we're preaching to the choir here. I think all of us have used probably the phrases that you've said, Mary, already, that why isn't it BLS? I get frustrated every time I have to do BLS, and you know, the chances of me having to use that are minimal. But I think there's two ways it can, but I'm heartened by not the fact that there is moral distress, but there is a lot of studies going on at the moment about moral distress in healthcare professionals. Locally, well, it's an interest of mine, so that's how I know that there's a lot of studies going on at the moment, internationally, collaboratively across Australia. And it speaks to what we started with, which was, you know, being pulled in different directions, you know, having to look after ourselves, as I think Kirsten and both Laurie said, you know, we're frightened for ourselves and our families when we're put in the COVID situation. And the same goes if we're facing mortality, we're perhaps just less conscious of it more than anything else. But then there's the distress of just holding distress more than anything else. And if we can communicate about it, that makes it a lot easier. So there's only two ways it could get higher capacity built into the system. One is if we demand it as healthcare workers, that we want this training. You know, this research is showing that if we can speak this language and it's part of our workplace health and our mental health, and let alone our patients' mental health, then we demand it as part of our training. The other is that it becomes mandated because of the same, that we work better and patients' needs are met better. But I think the first thing to recognise is it's really key to our own practice, our self-care. We haven't talked about is teamwork and self-care, which we might spend the last little bit talking about. So our own self-care, but the care of our patients as well too. And again, finding those moments to have really difficult conversations so we can set everybody up to have a good death. And they're not boutique deaths, it's just the general experience of death and dying wherever you may be.
Mel, within your organisation, have you made any inroads?
From that point of view, we have frequent conversations at an end-of-life care committee. We're lucky at Peninsula Health to have an end-of-life care committee where there's multi-disciplines that attend. This comes up, and I see Bruce there hiding down the bottom here. This comes up a lot, is talking about communication skill training or breaking bad news, advanced skills training. And I speak to Jerry's colleague about this a lot. So it's something that we talked about but not activated per se. I think we had a lot of skills and mentoring, intense mentoring, as I said, when I was remotely supervising a COVID ward, about how to coach the junior staff in having these conversations, that sort of thing. Another one of my colleagues is hoping to use the SIM Centre at our hospital to do our own teaching of medical students and junior medical. But you really do, you need, if it's going to be, and I'm using the medical paradigm, but nursing is much the same. You've got to do it before they become clinicians. You've got to do it when they're junior clinicians and they're being non-verbally taught the wrong thing by their senior clinicians. Then you have to teach them, reteach them again when they're senior. So it's a big undertaking. So it really does take an organisational, if not a societal commitment to it. What we can do is model it as specialists in this area, and we can ask our colleagues to advocate for themselves, seek it out, but then also advocate for themselves as well. And that's how I would go about it. But, you know, there's so many resources and there's so much evidence about it, but it comes down to what you started off saying, John. It's a soft part of healthcare is managing that, you know, if it's not therapeutics, it's the soft part of healthcare, which is, you know, it value-wise, health economics-wise, it's actually would be very potent. It's just not sexy enough. We just have to make it sexy.
Yeah.
Well, you can do that, John.
Well, I think it's very interesting, Mel, because the evidence is quite clear that therapeutic communication predicts outcomes for patients. And you know, if we do take the analogy that, and you guys would be all familiar with this, I guess, but you know, there are certain treatment protocols which say if you've got this diagnosis and this set of symptoms, you get this kind of treatment. That's what treatment guidelines are. And if you don't follow that treatment guideline, then you're doing something which would potentially draw attention to your practice or your competence or your knowledge or something like that. But it is interesting that communications skills as a therapy or as a therapeutic variable are completely at the discretion of the individual clinician. Imagine if other treatment guidelines were completely at the discretion of the individual clinician. And so that's the dilemma I think we've got philosophically and ethically. You know, we embrace standardisation or at least minimal competencies in a whole range of other areas. And in this area, we have not got to that. We haven't got to recognising the sort of justification, if you like, for adopting a similar perspective.
Yeah. It's an implementation challenge more than anything.
I think a bit of answer to your question, Mary. I think only way I could think of it becomes more national level is if we could somehow push, because there is still these things happening in organization levels, but in variable situations and there are priorities. So if we want to have this across the country, I think it should become more like a national standard to push all the organization to adopt it. So otherwise, if they don't have, organizations don't have enough push for it, I think it's going to be not taken seriously from some. Yeah, it depends on the organization and their values as well.
And I think that's a good implementation point, is that it comes down to the carrot and stick that I was sort of alluding to before. But I think if it became part of Standard 5, I think you'd find it happening very quickly. And it may well do, I suspect. And that's where I think, you know, that's within the acute sector for those of you who don't work in the acute sector, but that's about comprehensive care management in particular. Okay, we've got 5 more minutes, and I don't quite know where to chat to next, but I'm just going to make a decision. I think my experience, and I'm not going to do a case, or maybe I am the case, that when we were and you would have heard Frankston Hospital was right in the middle of one of the dumpster fires during COVID, and it was really challenging for me because I was split from my team. So the reason I was working from home and I was furloughed for a little bit without COVID, but we obviously, all of us were either contacts of contacts. So there was furloughing, but we were, again, all of that risk management, our little team was split and we weren't working together. 2 of us had to work remotely. Everybody else was working separately. And it really made me very conscious of how important it is to work in teams when you're working with people at the end of their life. So, and whilst in palliative care, specialist palliative care, we're lucky because we have those teams in place. For those who work in little p palliative care, so those who are doing palliative care but are not specialists in the area, but the load is the same, if not more, that you really need to think about crafting those groups for yourself as well. And so that was really important. It's not something that we've talked about in this series of Time of Dying, although I mentioned it in a few of my talks. Just the absence of having a team when facing all of this made it really apparent how important having a team is to practice and practice effectively in the end-of-life care space. I wonder if anyone else has a comment on that in the last 3 minutes before we go.
Well, I think, Melanie, you're alluding to the importance of social and emotional support. And it is interesting that at a time where the stress demand, if you want to call it that, goes out through the stratosphere, at the same time, your access, or not just yourself, but often other people as well, this notion of splitting resources and so on and so forth completely, invalidates that idea of the importance of support and maintaining it, and particularly maintaining it, I think, with trusted and competent colleagues. I was having a discussion with somebody the other day about supervision, and supervision's great when it occurs in a trusted context where you get valuable feedback. But if it occurs in a context where there's no trust and no credibility, it's probably worse than nothing at all. So I think it's interesting, how we think about those next steps. Clearly, this was a bit of a dry run. We got smashed this time, and we probably didn't have all those systems in place. But given the investment in the preparedness to invest in PPE as a risk management factor, what's the risk management strategy for psychological wellbeing for health workers? It's a fair question.
To John, we used our community of practice, and John would come into the community of practice. So people that were perhaps isolated across the region would get together, I think 3 or 4 times over that COVID period, and just have a bit of a discussion, talk about any issues that might come up, any struggles and challenges that people were having. They were able to discuss it in a team if they weren't able to work with their teams all the time. So I think that really showed how valuable it was, and we hope to continue to do that.
And I think yep. We might, in the interest of time, sorry, John, I've dipped you in the bud there, but I think that principle of a community of practice is really important for anybody, for the panel members and for beyond. I think we would all welcome those of you who are not specialist healthcare clinicians to tap into the resources of your local community palcare service if you want to debrief, even if it's a client that's not well known. Certainly we work in this space and we have lived the experience that everybody has lived through. So it's certainly one place to touch base with the consortia or through the primary healthcare network. Because again, if we don't discuss these things and the importance of it, then it's a missed opportunity as well. So sorry to cut you off, John.
Look, just very briefly, I just wanted to, acknowledge Annie was really the driver for setting up my involvement in that, and I think it reveals how important it is to have somebody you can see a bit further down the road. Yeah. But the other aspect of that is that, in I think the first couple of meetings we had maybe 20 people, and maybe we only got 3 or 4 people contributing, but the vicarious benefit is still very, very powerful, I think. And it takes some people a little while to warm up, to feel like, okay, this is a forum where I can actually comment or ask a question. So, as in any relationship, those things might take a little while to unfold, but they can be incredibly powerful, and particularly for people in, Bruthen and Buchan and all over the joint, where they're not going to get that kind of access by face-to-face contact necessarily very often.
Right. Well, that takes us to 8:01. I didn't know how we were going to do that with any planned cases, but we did very well. Thank you, everybody, for participating and listening. I want to thank Indra. I want to thank John. I want to thank Laurie, and apologies, Laurie, and thank you again, Laurie, and Jenny, and of course, everybody else who's participated. Certainly make contact with Annie and the consortia if you're interested in a community of practice or any future talks. Annie's the woman to help wrangle us in a palliative care or parallel supportive care place. We're happy to do these sorts of talks into the future. I'm speaking for the collective. Thank you again. Catherine, did you have any final words that we needed to finish up with?
Just thank you, Melanie, for facilitating tonight. I think you did a fantastic job. And the panel, Laurie, John, Indra, Jenny, well done all. And also to everyone who participated, put the time aside for this important topic. That was great.
Well, thank you, everybody. Thank you again for at the end of the Whole Time of Dying series. And hopefully we can do it again in a hybrid format next year.
Yes.
Merry Christmas to you all.
Christmas. Thank you.
Thank
Bye.
you.
Thank you.
Bye-bye.
Bye bye now. All the best.